starting with the HER2 zero, of course. So they found that, when you do one biopsy, chances of having a HER2 low is about 60%, and having a HER2 zero was about 40%. And then if you take those 40% of the patient who had HER2 zero, do another biopsy, chances are another 30% of them will be labeled as HER2 low, and you will be left with about 60 or 70% of those that will be HER2 zero. Now keep doing that. Keep repeating biopsies on those that remain HER2 zero. After 4 biopsies, chances are 98.9% of the patient will eventually become labeled as HER2 low. So that tells you, I mean, if you, it's just a matter of doing more biopsies, you're going to get to HER2 low, right? So it's really not this marker that is set in stone. It changes, and if you do more biopsies, you're going to get it. Chances are you're going to get it. Not only that, the site of the biopsy matter. This was another paper published in European Journal of Cancer in 2023, showing that they biopsied multiple different sites in each patient. And they saw that HER2 expression is very heterogeneous depending on the site. So some patients, as you can see here, had HER2 positive to HER2 low to HER2 zero at different sites in their body. So really, it's not a great marker, especially when we use IHC. Now, if you look at the ASCO-CAP guidelines, and the ASCO-CAP guidelines were recently updated in late 2023, so early 2024, to standardize how we label HER2 testing. And they clearly say that pathology report should include the IHC interpretation as negative, positive, and specify the staining pattern. So 0 with no membrane staining, or 0 plus with membrane staining. So 0 plus is the ultra low, 1 plus, 2 plus, 3 plus. And they even go further to say you need to give a quantitative, so a percent estimation of the staining. So is it less than 10%, more than 10%, 20%, 30%? So for example, HER2 negative, 1 plus, 20%. Or you can put, for example, HER2 negative, 0 plus, 5%. So something like that. So this is the standardized way that reporting should be done on pathologies. Can I tell you that this is not being followed? A lot of places are not following that, but this is how it should be. Now, in the footnote, they say you should include it in the main report. In the footnote, you can define low and ultra low. And you can use clinical trial setting definition, put it there, but as a footnote. But you shouldn't be on a standardized pathology. The word HER2 low and HER2 ultra low should not be used. They should give you a qualitative and quantitative measure, like tell you the specific staining pattern and give you a percentage. So, and I hope in the near future, everybody will have that, because that can make it much easier for us to interpret and see which patient qualify for treatment. All right, so now let's talk about trastuzumab deruxtecan mode of action. Antibody drug conjugates are fascinating, and they are the one reason why I joined breast oncology, because of, in 2013, we got the first approval of TDM1 or Kadcyla at that time. And, it was something like science fiction. You have this antibody that roams the body looking for a specific target, binds to it, and only where it binds, it has a payload that will kill that cell and spare the healthy. I mean, it was something like a sci-fi movie. So I loved it, and it captured my imagination. But this is basically what ADC do. So ADCs are antibodies that have a payload attached to them. They go around the circulation, they go into the third space area, and they look for a specific target. Trastuzumab deruxtecan looks for HER2. When it binds, it gets internalized, and then inside, because the linker is hydrolyzable, it can only be cleaved inside the lysosome, inside the tumor cell. Then the payload is released, and as the payload gets released, it kills the tumor cells. But also the beauty about trastuzumab deruxtecan, it has the bystander killing effect. So it happened to be that as soon as it attaches to the surface of the cell, there are some cleavable enzymes that can cleave the payload. So some of this payload gets released before even getting internalized. But even as the antibody gets internalized and gets through the lysosome, when the payload is released, this payload can diffuse freely across the cell back to the environment or microenvironment of the cancer and kill cells in the vicinity of that cell. So this is the two mode of action, how it kills cancer. Now, if you look at it specifically, the payload is a topoisomerase 1 inhibitor. The DAR or drug to antibody ratio is 8 to 1. So each antibody has 8 payloads attached to it. I always say the hero of the ADC is the linker. The linker is the hero because this linker here is a protease cleavable. So it needs a protease to cleave it. It needs a specific enzyme. When you don't have a cleavable linker, then the antibody drug conjugate is essentially just chemotherapy because as soon as you give it into circulation, the payload will leave the antibody and it acts like chemo. But this drug here, the linker is cleavable and makes it very specific, more targeted, and you can give a higher dose. The median half-life of the payload is long, 5.5 days. That's why when you give trastuzumab deruxtecan, you can give it every 21 days. You don't have to give it more frequently. If you want to compare this drug with another antibody drug conjugate that we use, like sacituzumab govitecan, for example, sacituzumab govitecan, the median half-life is only 24 hours. That's why you have to give it on day 1 and day 8 because it doesn't last long. This drug, 5.5 half-lives. You need 5 half-lives for a drug to disappear. So you're doing it every 21 days is more than enough to always have some drug going around the body. All right, now let's talk about the data that we have in the HR positive, HER2 low space. So the first study we're going to talk is the Destiny Breast 04. The Destiny Breast 04 was a phase 3 study that looked at HER2 low patients who received at least one prior chemotherapy once they became refractory. So they allowed 1 to 2 prior lines of chemotherapy. However, patients who were primary endocrine resistant and basically had a recurrence within 6 months after receiving adjuvant chemotherapy, usually at that time they're receiving their adjuvant endocrine therapy, they were allowed to enroll automatically on that study. And usually they should have received 1 prior line of endocrine therapy plus minus targeted therapy in the metastatic setting. And they allowed the treated stable brain mets. Patients were randomized 2 to 1 to either receive trastuzumab deruxtecan or physician choice chemotherapy. The most common physician choice chemotherapy on that study was eribulin, right? Eribulin, because this was kind of second line in the endocrine refractory. Usually before, the majority of patients before they enrolled on this study received capecitabine already. So just remember that for that study. The primary endpoint was progression-free survival in the hormone-positive population, and the secondary endpoint was PFS in all population, because there was a very small cohort of about 75 patients that were triple negative who were enrolled on that study. So if you look at the progression-free survival, I mean, it improved drastically. It went from about 5.4 months to 10.1 months. I mean, doubling of the progression-free survival. Median progression-free survival. So half the patient did even better than 10 months. This is very exciting to see. And if you look at all patients, so including the small cohort of patients that are triple negative, it was still close to doubling of the median progression-free survival. Now, when you look at the overall survival, and this is the updated overall survival, it's really improved the outcomes. Like we see close to 2 years median OS with TDXT in the HR positive cohort and in all patients. But the side effect of the drugs seen generally evolve around nausea, fatigue, vomiting, and there is some of interest we're going to see in the next slide. So even more than the treatment physician choice chemotherapy, you see the nausea. But remember, when the Destiny Breast 04 was designed, patients were not getting very good antiemetics. So we're going to talk about that later on today in today's presentation. Just keep that in mind. So they weren't pre-treated adequately, and they weren't given good prophylactic as needed medication to go home with. And that's why they report close to 73% nausea on that study. Now, when you look at some of the side effects of interest with that drug, what's prominent here is the ILD, right? So the ILD is one of the main side effects of the drug, and it's something to always keep in the back of our mind. With TDXT, there was about 12% chance of ILD at any grade. Thankfully, the majority are low grade. However, there was 4 deaths. 4 patients died because of ILD on the Destiny Breast 04. So yes, it's rare, but it's really important to identify early. At the end of today's presentation, we're going to talk about ILD in much more detail and what we can do about it. Now, this is a HER2-directed therapy, so the other thing we worry about is worsening of the ejection fraction of the heart. We do see it. We do see a decrease in about 5% of the patient, reduced heart function. However, symptomatic reduction is only seen in less than 1% of the patient, which is reassuring. Now, there was an update at ESMO last year looking at some subgroup of interest, like patients looking at HER2 gene expression, looking at also HER2 mutation and HER2 status by IHC, whether it's 2+, FISH negative, or 1+. You can see across the board that patient who received TDXD did better than chemotherapy, patient who did treatment physician choice chemotherapy. But what's really interesting is that, for example, if patient have high HER2 gene expression, they tend to respond better to TDXD. Patients who have HER2 mutation tend to respond better to TDXD. Patients who are IHC 2+ FISH negative also had better responses to the one with IHC 1+. However, all of them, regardless, they did better with TDXD. It's just you can go more granular with those data. Then they looked at different populations of interest, like patient with BRCA mutation, for example, versus those with wild type. First, you can appreciate that patient with BRCA mutation, whether they receive TDXD or they receive chemotherapy, they tend to do worse than the patient who do not have those mutations. But even patient with mutation receiving TDXD tend to do better than treatment physician choice chemotherapy. The same thing was observed when you look at other HRD gene alteration. Always the wild type patient tend to do better than the patient with a mutation. But even though in patients who have a mutation, if you give them TDXD, they tend to do better than chemotherapy. And the last one they looked at is patient according to their stromal TILs, so tumor infiltrating lymphocyte. Here they found patient with high TILs tend to do better, which makes perfect sense because, antibody-drug conjugates are very immunogenic. They do stimulate the immune system. So if you already have that immune system in the microenvironment, stimulating it in microenvironment, you are going to see better responses because they're right there. They can join the fight right away. So that's what they found is that patients with higher TILs tend to derive more benefit from TDXD. Now, when you look at the overall safety of TDXD versus one of the chemotherapy that was used on that study, for example, capecitabine, you can see that overall adverse events, so drug-related adverse events, were similar between both. However, serious adverse events and adverse events that led to discontinuation were higher in TDXD compared to capecitabine. However, if you look at drug-related adverse events that were associated with dose reduction and dose interruption, they were higher on capecitabine. So that's a very interesting juxtaposition here. And what was really interesting is if you look at the patient-reported outcomes, you can see that the patient-reported outcomes on TDXD and capecitabine were similar until you reach cycle 21. After cycle 21, patients who received capecitabine did much worse, reported much worse outcome compared to TDXD. And that's very interesting because this is around the time, cycle 21, when the hand and foot syndrome becomes very prominent in patients. So saying that capecitabine, I'm going to give capecitabine because it's better tolerated, is not fully true. Because this is objective evidence that both are very well tolerated until cycle 21, where capecitabine patients do a lot worse compared to TDXD patients because of the hand and foot syndrome. All right, so now we're going to move on to the Destiny Breast 06. So the Destiny Breast 06 tried to build on the Destiny Breast 04, because remember, Destiny Breast 04, yes, they looked at endocrine refractory patient, but they looked at patients who already received at least one prior line of chemotherapy. The Destiny Breast 06 allowed patients to receive TDXD right after they are labeled endocrine refractory. So that's one thing that's different than the Destiny Breast 04. The other thing that's different here is they allowed a new category called the HER2 ultra low. So any membranous staining, so these are IHC 0, but with little membranous staining, they qualify and they're called HER2 ultra low. The third thing is that study enrolled 1-to-1. Remember, the 04, it was 2-to-1 randomization. Now, if you look at prior lines of therapy, they allowed up to 2 prior lines of therapy with endocrine therapy plus minus target therapy. Now, if they received, if they were going to enroll as first line for the DESTINY-Breast06. They need to have progression within 6 months of starting first line endocrine therapy plus CDK4/6 inhibitor, or a recurrence within 2 years from adjuvant endocrine therapy. So if patient was on adjuvant endocrine therapy, either while taking it or within 2 years of finishing it, and they had a recurrence, they can qualify automatically to that study. And this is, by the way, still in the label right now, at least in the US, to use it for patients after the FDA approval. So you can give it as first line. So patients were randomized 1-to-1 to either receive trastuzumab deruxtecan. Again, the majority of the patients were HER2 low, but there was about 20%, 15 to 20% that were ultra low, or go on to receive physician choice single agent chemotherapy. On that study, the physician choice chemotherapy, the majority was capecitabine. So remember the DESTINY-Breast04, the majority was eribulin. Here, the majority was capecitabine. If you look at the primary endpoint, which was progression-free survival by the independent blind reviewer, you can see that there was improvement of the PFS from 8.1 months to 13.2 months. Again, very substantial improvement of median PFS, because 50% of the patient did even better than that 13.2. So that's very exciting to see. Now, when you look at all the different subgroup patients, all of them across the board derived benefit from T-DXd compared to treatment physician choice chemotherapy, all of them. Now, when you look at the intention to treat population, so these are the patients that are HER2 low and ultra low combined together, you saw an improvement of median PFS in the same magnitude. So a delta or absolute benefit of 5.1 months with a median PFS with T-DXd of 13.2 months. Now, some subgroup population of interest, which is very reassuring, is how about the patient who had time to progression on the prior treatment of less than 6 months? So less than 6 month treatment on first-line therapy. These are the patients that we really worry about. So think about your patient that goes on first-line endocrine therapy plus CDK4/6 inhibitor, and they progress within 6 months of therapy. These patients usually have very poor prognosis, and these are the patients we worry about a lot. And usually before the days of ADCs, nothing really works, and the prognosis used to be very grim for those patients. These are the primary endocrine resistant patients. It's very interesting to see that those patients, when you give them T-DXd, look at their median PFS, 14 months. Very impressive, more than double of the one seen in the treatment physician choice chemotherapy. So this is very reassuring, especially in those hyper-progressors while on first-line therapy. But even in patients who are endocrine sensitive, who had a progression above 12 months, they still derive benefit of T-DXd compared to treatment physician choice chemotherapy with a delta or absolute benefit close to 5 months. Again, if you look at the table below, here they're stratified between primary endocrine resistance versus secondary endocrine resistance. Primary endocrine resistance based on the ASCO definition is relapse within the first 2 years of adjuvant endocrine therapy or within 6 months of first-line endocrine therapy plus minus targeted therapy. Sorry, let me go back. And here you can see that T-DXd is very active, doubling of the median PFS compared to treatment physician choice chemotherapy. Same thing is seen with secondary endocrine resistance. Secondary endocrine resistance, how it's defined by ASCO, it's an acquired resistance that happens after the first 2 years of adjuvant endocrine therapy or within at least a year of completion adjuvant endocrine therapy, or after 6 months after initiating endocrine therapy in the metastatic setting. Also, T-DXd improved the outcomes in those patients. Another subgroup of interest are looking at the different location of or the number of sites of metastatic disease. So you can see T-DXd is active even in patients with less disease burden. So this is the graph on your left-hand side. And in the patient who have significant disease burden, so more than 3 location of metastatic sites. So both those groups benefited very well from T-DXd. Now, when you look at the forest plot below, this is looking at different things. So if you look at liver disease, yes, no, T-DXd is active in both. If you look at the baseline tumor size, looking at the median, whether it's a high median or low median, both benefited from the similar magnitude. And if you look at visceral disease, yes, no, both benefited. So even patients with bone-only disease do benefit from TDXD. Now, this is here stratifying, because remember what I told you. In the DESTINY-Breast06, the predominant chemotherapy of choice was capecitabine. The second one, the close second, was taxane. So here they stratified them per the chemotherapy. So comparing TDXD to capecitabine, also TDXD came on top, 13.3 versus 8.5. So the idea of that we keep hearing that, oh, I'm going to give my patient capecitabine and not TDXD, for me is very flawed, because it was compared to TDXD and it wasn't the superior drug. So I still value TDXD over capecitabine for patients who qualify, not only because it's superior in terms of efficacy, but also the idea in our mind that it's better tolerated is wrong. Because PRO have shown that both drugs as good as tolerated till cycle 21. And after cycle 21, there is a sharp decline in tolerability of capecitabine because of the hand and foot syndrome, which is not seen with TDXD. Now, same thing when you look at TDXD versus taxane, TDXD come on top, no shocks there. All right, now here we're looking at the overall survival. The overall survival data is not mature yet, so we cannot make definitive decision on survival for the 06 data. The 04 has already been done and dusted. So here you can see at least that both curves have separated and they're not meeting again. So this is reassuring, but again, we need more long-term follow-up to have the final overall survival data. And this is a slide here looking at the ultra-low population. So the ultra-low have huge interest from us because that can really expand who can get the drug. And you can see, I mean, the benefit is clear. If you look at the PFS, it improves from 8.3 to 13.2 with a delta of 5 months. Similar magnitude what we see in the low patients. And overall survival, also the curve have separated, but it's still immature. But the benefit is consistent in the low and ultra. And when you look at anti-tumor activity, this drug is very, very effective. So if you look at the overall response rate, it doubles when compared to treatment physician choice chemotherapy. So with chemotherapy, we expect about 30% response rate. With TDXD, it's closer to 60% response rate. And that's consistent, again, in the HER2 low and ultra low population. And this is the patient-reported outcome on the DB06. Look at those curves. They speak for themselves. The blue curve is a TDXD. The gray curve is a treatment physician choice chemotherapy. Again, the treatment physician choice chemotherapy mainly is capecitabine. So this is mainly comparing TDXD to capecitabine. And the patient-reported outcome are so much better on the TDXD compared to the treatment physician choice, which mainly is capecitabine. Now, at this recent ASCO, they also showed us some population of interest looking at the activity of TDXD. So the first one is the patient with alteration in PIK3CA, AKT, PTEN pathway. And you can see that TDXD is very active in a patient with those mutations compared to treatment physician choice chemotherapy. Same thing in patient with the ESR1 mutation. So if you have a patient with ESR1 mutation, giving them TDXD is also very effective based on that study shown here. And also patient with BRCA1 and 2 mutation. Although in general, patient with BRCA mutation tend to do worse than the patient with wild type. But here you can see, I mean, patients do very well when they receive TDXD regardless. So back to the patient-reported outcomes, you can clearly see that TDXD patients do better in terms of physical functioning, emotional functioning, in terms of fatigue, and in terms of pain. Patients with TDXD do better in terms of nausea and vomiting, and that's very closely related to the appetite and to the constipation. So basically, if you can control the nausea in your patient with TDXD, it should be very well tolerated. And we're going to talk about those in a little bit. So finally, when looking at the DESTINY-Breast06, looking at the safety summary, in general, it was well tolerated, but you can see that treatment duration was much higher on TDXD compared to chemotherapy because it delayed progression. And treatment most common adverse event associated with discontinuation. On TDXD, it was pneumonitis in 5% of the cases, and the treatment physician choice chemotherapy was neuropathy. But the most common adverse effect associated with dose reduction on TDXD, it was the nausea, but on the treatment with choice chemotherapy, it was the hand and foot syndrome, and 16%. So if you look at that, it's 4 times higher, the treatment dose reduction because of hand and foot syndrome. So again, the main side effect of TDXD is the nausea. And you know, the fatigue and all the others, the decreased appetite, and that is related to the nausea. ILD, remember, is very rare on TDXD, but the most common side effect is nausea. So we need to do a very good job at controlling and preventing that. So looking at ILD on the DESTINY-Breast06, it was reported close to 12%, so similar to DESTINY-Breast04. But again, three deaths were seen on the DESTINY-Breast06 because of the ILD. So very important to monitor for ILD, detected early, treated early, and we're gonna go over how to manage that a little bit. Again, like we talked about before, because it's a HER2-directed therapy, we always worry about cardiovascular events. So looking at the LV function, with TDXD, you see a reduction in about 8% of the patient. Thankfully, however, the majority are asymptomatic. Less than 1% of those lead to heart failure. All right. So now briefly, we're going to talk a little bit about how to manage side effects with TDXD. So the main side effects, as we went over it, is the nausea and vomiting. So the nausea and vomiting is really prominent. Now, if you look at the DESTINY-Breast04, prophylaxis was not mandatory per study protocol. It was only recommended. Now, because of that, we've seen a lot of nausea reported on those studies. So if you look at, for example, the dose reduction associated with nausea vomiting, it was about 5% in the TDXD versus 2% on the treatment with choice chemotherapy. If you look at the drug interruption associated with nausea vomiting, it was about 1.3, and discontinuation was 1 patient only. So although the nausea was there, however, it didn't lead to a lot of discontinuation at all, actually, and lead to some dose reduction and interruption. But what's really recommended nowadays is to do 3 classes of antiemetics. So TDXD should be treated as a highly emetogenic agent, and it should be getting a triplet regimen before the infusion. So the way it's recommended now by the NCCN guidelines since 2023 is to give first a 5-HT3 receptor antagonist. So either Zofran or ondansetron. But what I really like is Aloxi. Palonocitron. So that's my favorite one in my practice. I really like this one because it truly lasts for 7 days. It doesn't give much constipation. It doesn't give much headache. So I really like the Aloxi. But combined with it, we should give an NK1 receptor antagonist. So mainly what we use is Amend, which is 150 milligram IV, and we give this pulse dose steroid, dexamethasone. You can do 8 milligram, you can do 12 milligram. So triplet regimen should be given before giving TDXD. But this is not enough because about 30 to 50% of patients will get some delayed nausea vomiting with that drug. So it's really important to do patient education, give them rescue medication to go home with. So a lot of times we always give them, like Zofran or ondansetron, and we give them Compazine to go home with. Some people also give lorazepam. But what's really remarkably effective at reducing nausea is olanzapine. Olanzapine is a godsend medication for that drug. The way I do it, I give all my patients a low dose of olanzapine, either 2.5 milligrams. Sometimes I even tell them take half of that, 1.25 milligram. And I tell them to take it every single night, continuously, as we give TDXD. I mean, this low dose really doesn't have any side effect, but it does control the delayed nausea effectively, immensely, to the point that patient doesn't even take those rescue patients. I mean, it's so good at controlling the nausea from that drug that it became a standard. Anytime I prescribe TDXD for my patient, I always prescribe them a script of olanzapine daily at night, There was a study showing that if you do olanzapine at bedtime on day 1 to 5, it's also effective. In my opinion, I see patients on week 2 that still have the nausea. So I just tell them take it continuously as we're giving TDXT. And I haven't had any issue with that. In fact, my patients do fantastic when I give them TDXT. Lastly, we're going to talk about ILD. ILD, or what's more commonly known by pneumonitis. So that's what a study published in ESMO Open that pooled all the studies looking at TDXT, not only in breast cancer, but also in GI cancers and lung cancer. And I wanted to see is what can we learn about ILD? So first, what they found is that ILD happened usually after 6 months of treatment. So after about cycle 8. So at cycle 8, cycle 9 of that treatment, you do see the ILD. And the incidence, looking at the grouped analysis, was about 15%. But thankfully, the majority of those ILDs are early grade, so grade 1 and 2. And close to 90% of patients got their first ILD event within the first 12 months of their treatment. So these are something we can use in our practice. So in my practice, I worry about ILD the first 8 to 9 cycles. And after a year of treatment, I tell the patient there is still a chance of ILD, but it's unlikely at that point in time. But what that study also showed is that they looked at the risk factor, potential risk factor associated with higher risk of ILD. So one of them they found is younger patients. So patients less than 65 are at a higher risk for ILD than older patients. This one is the only puzzling one for me between the rest of the list. But that's what the result showed. If you look at the country of origin, because the study, almost 50% of the enrollee were from Japan over all the studies, because, who developed the drug are Daiichi. Daiichi is a Japanese company, so that's why a lot of Japanese patients were on that study. So they found that the Japanese population were at higher risk, twofold increased risk of ILD compared to non-Japanese patients. If you look at lung comorbidities, so patients with the history of COPD or asthma were at a higher risk, also about twofold higher risk to develop ILD. What's really interesting is baseline renal function. Patients with moderate to severe disease had close to threefold higher chance of developing ILD compared to the patients that are normal. And then if you look at the time since disease diagnosis, so first diagnosis, so the longer the time, 4 years or more, the higher the chance. That's because why? That's because they're getting TDXD as later line. So the more you give TDXD at a later line, the higher the chance you're going to develop ILD. The earlier the line, the better. Then if you look at the dosage, the higher the dosage, the higher the chance of ILD. And finally, looking at the baseline, SpO2, or oxygen saturation. A baseline oxygen saturation below 95% double the chances of developing ILD in your patient. So these are very important data. So because of that, what is recommended is to check patient with TDXD more frequently with scans. So usually what we do in our practice when we are trying to stage metastatic patient, we stage them every 3 months, right? Except my patient on TDXD. Those patients, I stage them every 9 weeks. So every 3 cycles of TDXD, because I want to check their lungs, make sure if something happening with their lungs, I want to catch it very early. I want to catch ILD very early. Because remember, grade 1 ILD is ILD caught on imaging without any symptoms. And that's where you want to catch your patient. You don't want symptoms to happen. So the recommendation, and this is something published by Dr. Hope Rugo and JCO, before treating with TDXD, get a complete history and physical, do a high-resolution CT, or basically the way I do it, just I get a regular CAT scan, chest, abdomen, pelvis, but I tell my radiologist that I really want a detailed report about their lung. We get a baseline SpO2, consider pulmonary consult for patients with significant lung comorbidities, or if the baseline SpO2 is below 95%, and we provide them education to what to look for and how to notify us if something happened. And while on treatment, again, the way we do it now, at least at MD Anderson, is every 9 weeks. Every 9 weeks, we repeat the scans. So what do you do if you are suspecting ILD? So if you are suspecting ILD, consider consultation with a pulmonologist right away, because Those patients, you need at that point to do a high resolution CT of the chest. Again, we tend to send them to our pulmonologist right away. Make sure it's not an infection. So blood cultures are important. CBCs to look for white counts and other stuff are important. Bronchoscopy is considered at that time, and usually our pulmonologist will perform PFTs on those patients. Make sure to stop the drug. So hold the drug at that point and evaluate the patient. So for grade 1, so asymptomatic, so patient have no symptoms that you find on imaging, delay the dose until recovery, so until it goes back to grade 0. For patients who are grade 2 or above, symptomatic patient, then you have to permanently discontinue. Try to initiate steroid as soon as you confirm there is no infection. So for grade 1 asymptomatic, consider steroid treatment as soon as you diagnose it, again, after confirming there's no infection. And the way we do it, honestly, initially we used to do this 0.5 milligram per kg prednisolone, but now we just give them a middle dose pack. Now, for patients who are grade 2 or above, promptly initiate steroid treatment as soon as possible. And for those, we do give them the 1 milligram per kg, so higher dose. Now, when do you resume therapy? Remember, resumption of therapy is only for patients who are grade 1 that go back to grade 0. If the patient go from grade 1 to grade 0 within 28 days, then you can go back on the same prior dose. However, if the patient, it takes longer than 28 days to go back to grade 0, then you have to reduce the dose by 1 dose level. Remember, the initial dose of TDXD is 5.4 milligram per kg. So the first dose reduction is at 4.4 milligram per kg, and the final dose reduction is at 3.2 milligram per kg. Do not re-escalate if you diagnose them before with TDXD. So if you de-escalate to 4.4, don't go back to 5.4. Even if they don't develop any more ILD, do not go back to 5.4. Keep them at 4.4. And these were the recommendations that were presented at an abstract at San Antonio Breast Cancer Symposium. And with that, I want to thank you, and I will take any question you might have.
Perfect. Thank you very much, Dr. Muavi. That was an excellent presentation. Actually, it was a good refresher and good clinical insights on what these drugs now have changed the overall space for hormone receptor ultra low, HER2 low and HER2 ultra low metastatic breast cancer. So I don't know if anybody has a question. Feel free to either post it in the chat or just raise your hand, and we are happy to ask Dr. Muavi to answer them. So I will be starting with a question in the meantime while people is thinking if they want to ask or not. First question would be like, I don't know, and particularly this talk was mainly for HER2 low, HER2 ultra low, and hormone receptor positive. And we know that, as you mentioned, sacituzumab govitecan is also an option for some of these patients. Would be there any specific type of patient where you would offer sacituzumab govitecan versus TDXD, like other than having an actual contraindication for TDXD, like an ALD or COPD or like some really bad pulmonary comorbidities? Would be any specific patient that you would say, okay, I would prefer to go and give this patient sacituzumab?
So 2 things I don't like about sacituzumab. First is that, again, for me, any ADC, the linker is the hero. Always look at the linker because it tells you a lot of information. The linker in HER2 is a protease cleavable. So you need a protease, you need a whole enzyme to cleave it. So that enzyme is either present at the cell surface or inside the cell. SG is the hydrolyzable linker. To hydrolyze a linker, you don't need an enzyme. So as soon as you put it in circulation, the linker gets hydrolyzed. In the blood, it can get hydrolyzed. So that's the problem. So a lot of drug get released with SG before it even reaches target. That's why you see the hair loss, by the way. Deroxtican, when we used to give deroxtican in the 90s, we had a study at Anderson phase 1 with deroxtican, notoriously drug. I mean, very bad. People used to lose their hair from the first infusion. But yet, when you use a protease a cleavable linker, you don't see the hair loss with TDXD because you're doing it very targeted. The reason you see a lot of hair loss with SG is because you're releasing that drug in circulation before it reaches target because of the linker. So that's something I don't like. The other thing I don't like is that the half-life of the payload is only 24 hours. So 5 half-lives mean 5 days, right? Because it takes 5 half-lives for a drug to be undetectable. So that's why SG, you have to give it on day 1 and day 8. You have to. There is no choice. If you give it day 1, day 15, it's not going to work. Whereas TDXD is a 5.5 day half-life. So 5 times that is what, 26, 27 days, 28 days. So you're giving the drug every 21 days, so that will always drug in the body. So for me, it's a much more effective way to give TDXD than to give SG. That's why forget about the drugs, forget about, just looking at the biology of those drugs, one of them makes much more sense for me to use than the other one.
That's fair. Thank you for that answer. So another question that I was thinking about is, as you probably know, here in Canada, we depend on the ministry approvals, and so far for us, having TDXD approved in the metastatic setting for hormone receptor positive breast cancer, it's only possible after a first line of chemotherapy based on the Destiny-04 data. As you know, the Destiny-06 data is telling us that there's a PFS benefit, but not an OS benefit. I would gather that in your practice, you're first to go once these patients progress on CDK4/6 inhibitors and endocrine therapy, they would be put on TDXD. Is that how you like operate in your clinic? Is that like your preferred approach? And in light of not having an overall survival, which I know still is in development,
Mhm.
which I know also sometimes we don't get OS benefits, but still PFS could be a valuable outcome to get. I don't know if you like ever like go with capecitabine first or like any other regimen before starting TDXD for any patients.
Yeah. So thankfully in the US, the O 06 already FDA approved, so we can go straight to it. But before the date of the O 06, yes. So we used to give capecitabine before doing TDXD. That is true. Except in some cases following the O 04 design. So in patients who are hyperprogressors from the adjuvant setting, so you see those patients who get chemotherapy and then you start them on endocrine therapy plus minus CK4/6, and within 6 months they have a progression. Those patients are unlikely to benefit anymore from endocrine therapies. And I worry about those patients even to go with capecitabine. I mean, those patients need the best available treatment right now. So those, we work hard to get them TDXD right away.
With that in mind, that now that you have touched on an interesting point there, now with all the advancement of these PIK3CA, ESR1, and mutations that we are looking at, where there be like a specific subtype of patients that you wouldn't like offer TDXD? Like obviously, if you have access for ESR1, we currently in Canada we don't have like any access to that.
Mhm.
But we're waiting. But if there's like if you have the PIK3CA, would you go like let's say capivasertib first and then TDXD, or how would you sequence your treatment in those?
Mhm. Mhm. So the rule of thumb is as long as patient qualify for endocrine therapies, you want to exhaust your endocrine therapies plus minus target therapies before you move on to something like an ADC. However, having said that, the most important marker currently we have of endocrine sensitivity after first-line therapy with the CDK4/6 inhibitor is how long they responded to the first-line CDK4/6 inhibitor. And the number to remember is 12 months. So patients who respond for at least 12 months on a first-line CDK4/6 inhibitor plus endocrine therapy, those are deemed to be still endocrine sensitive. And those should receive another line of endocrine therapy plus a target therapy depending on what they have. So if they have ESR1 mutation, you can do something like elacestrant. If you have a PIK3CA mutation or any alteration in the PI3 kinase AKT PTEN pathway, then you can give them capivasertib or one of the other targets. Now, if the patient go on CDK4/6 inhibitor plus endocrine therapy and they progress within 6 months. This is a clear-cut case that we should not, even if they have a mutation, they're unlikely to respond. And that's what the studies have shown, by the way. If you look at the Emerald study, patient who did not have a response of CDK4/6 inhibitor plus endocrine therapy of at least 12 months, elacestrant did not work well. Same thing if you look at the Capitello 291, the patient who didn't have a good response to first-line therapy also didn't do that well when you look at the subgroup analysis. So those are essentially endocrine refractory, and we have to move on to something like an ADC or chemotherapy. But what do we do between the patients that are between 6 months to 12 months? I mean, these are always the headaches. So then we individualize the decisions for those patients. So a lot of factors come into play here. Mainly the site of disease. Is it visceral or is it bone only that we're seeing? A lot of time we feel more comfortable if it's bone only to do another line of endocrine therapy or target therapy. However, if the disease is in the visceral organs like the liver and the lung and progressing, we want to go to something else like an ADC uh, uh, um, or capsaicin.
Perfect. Thank you very much for that insight. Actually, I think it's really important for us to always remember about the sequencing, like taking into account the time the patient was sensitive to prior therapies. And I don't know if anybody else has any other questions in terms of symptom management or side effects, or is there any specific question that anybody would like to ask? Okay, perfect. So just out of curiosity, I found it intriguing the fact that you're with some patients you're even giving olanzapine 1.25 milligrams. We have like a really amazing pharmacy team here that actually help us with all of that. We have a really good template on what drugs to give. Obviously, the most challenging side effect of olanzapine is feeling drowsy, which a lot of patients hate. But in your experience, which patients do you normally like offer 1.25? Just out of curiosity,
No,
intriguing.
you nailed it. I tell my patient take the 2.5 at night. Some patient wake up in the morning groggy
Mhm.
with the 2 point. Very little. I would say like 1 to 2 out of 10 patients. They wake up still a little bit groggy in the morning, kind of, and they call it twilight zone. They don't like that feeling. So those patients, I tell them take half a tablet, and it works well.
Right.
Yeah,
Thank you. Yeah, no, that's
yeah,
kind of those practical questions that I think it's always
yeah.
important to ask. Yeah, so I'm not sure if anybody has any other questions. If not, we want to thank Dr. Muavi for this excellent talk, and we will be reaching out to you as well for other for if there is any question, particularly from this talk. But otherwise, we appreciate your time. We appreciate this talk, and thank you very much for attending today.
It's an honor. It's a great honor. Thank you so much for having me.
Thank you very much, and have an excellent day. Take care.
Same to you. Bye bye, all.